Hello and welcome back to my channel, Dr. Neurosurgery Greenberg. Today we will be looking at pituitary adenoma clinical considerations. And what you need to remember is that most of the pituitary adenomas are benign, but some can be aggressive or metastasize. Now, what are the symptoms? Sometimes there are symptoms of oversecretion, like hyperprolactinemia, Cushing syndrome, which is increased cortisol, acromegaly, increased growth hormone. Then there is mass effect. From mass effect arises visual disturbance like bitemporal hemianopsia from compression of the optic chiasm, or infrequently there is hypopituitarism due to compression of the pituitary gland. Then there is headache due to increased pressure within the sella. Sometimes it can be an incidental finding. It can infrequently present as pituitary apoplexy or spontaneous CSF rhinorrhea. Workup includes endocrine testing, visual field evaluation, imaging to look at the tumor, the paracellular carotid arteries, and the sphenoid sinus. And prolactinoma is the only type for which you have to give medical therapy, dopamine agonist. For the others, you have to do surgery. Transsphenoidal, sometimes if the tumor is very big, you go for transcranial, or you can also go for radiotherapy. Post-op, you have to look out for diabetes insipidus, adrenal insufficiency, CSF leak, and sometimes the vision can deteriorate due to herniation of the optic chiasm into the empty sella. So we all know that most primary pituitary tumors are benign and they arise from the anterior pituitary or adenohypophysis as a monoclonal proliferation. But you have to remember that not just one hormone is affected. Usually a group of hormones is affected. If only one hormone is affected, then it means that it is autoimmune hypophysitis. So there are two types of adenomas. One is the microadenoma, the other is the macroadenoma. Micro is less than or equal to 1 centimeters in diameter, and more than 1 centimeter is macro. Then there are some tumors that are null cell adenomas. They don't have any specific type cell, and they don't have any typical molecular staining or molecular pattern. And it is not non-functioning, it is just that no endocrine syndrome is associated with these tumors. And even though they are secreting something, but they are not causing any hormone problem. And usually they occur after 60 years of age. So now the most common pituitary adenomas are the non-functioning ones, whereas Cushing's disease and prolactinomas are more common in females. Non-functioning lethotroph and null tumors are more common in males. Then we have some tumor classification according to the molecular. So broadly speaking, PIT1 lineage tumors are the growth hormone, prolactin, and TSH secreting tumors. Then there are TPIT tumors. They are the ACTH secreting tumors. SF1 secrete gonadotropins, and then there are some tumor cells that have no lineage. They are the null cell tumors. Other than that, sometimes pituitary adenomas can be part of a syndrome, or they can be sporadic. Most are sporadic, but sometimes they can be part of other syndromes like multiple endocrine neoplasia, or like they have pituitary adenomas, pancreatic islet cell tumors, parathyroid tumors, and then there is Carney complex, which is autosomal dominant. There is cardiac cutaneous myxoma, hyperpigmentation, pituitary adenoma that is going to secrete growth hormone and prolactin. And other than that, there is McCune-Albright syndrome, in which there is mammosomatotroph and somatotroph tumor or hyperplasia, and there is tuberous sclerosis, in which corticotroph tumors are secreted. Then how do the clinically the pituitary tumors present? So first of all, we are going to look at symptoms of over secretion, hormone over secretion. So the first hormone to be elevated is prolactin, then growth hormone, then ACTH, and then TSH. If prolactin is more, then it will be either due to two parts, prolactinoma or a stalk effect. We will discuss this later, but you have to remember that they are two different entities. Other than that, there is growth hormone secretion. When it is more, then there is acromegaly. And in children, it is gigantism. Corticotrophin, ACTH, causes Cushing disease or Nelson syndrome. TSH causes hyperthyroidism, central hyperthyroidism. Gonadotropins, if they are increased, then they can produce ovarian hyperstimulation syndrome in women or testicular hypertrophy in men. And then there is presentation due to mass effect. The first thing that the huge adenoma is going to do, the non-functioning one, is that it is going to compress the stalk. When the stalk of the pituitary is compressed, then hypothalamic factors flow is interrupted. So most of the hormones are going to be underproduced, and but prolactin is going to be generally increased. This is called stalk effect. That actually the tumor has compressed the stalk, but paradoxically prolactin has increased. And this is because hypothalamus secretes stimulating factors for all the hormones except for prolactin, dopamine. Dopamine inhibits the prolactin and the production of prolactin. So when its inhibitory effect is lost, then prolactin increases. This is called stalk effect. And that is why when we look at the acronym, that is, go look for the adenoma please. Growth hormone is the first hormone and most commonly suppressed hormone. Then LH, then FSH, then ACTH, then TSH, then prolactin. Now, if there is chronic panhypopituitarism, it is going to produce pituitary cachexia, and that is called Simmons cachexia. The patient is very, very, very atrophied, emaciated. Now, if there is again only a single hormone is lost, but the rest are okay, then it means it is autoimmune hypophysitis. Autoimmune hypophysitis usually causes deficiency of ACTH or ADH, leading to diabetes insipidus. Now, when growth hormone is less, then obviously the children will have growth delay. In adults, it will produce vague symptoms and hypogonadism. Hypothyroidism leads to cold intolerance, myxedema, entrapment neuropathy like carpal tunnel syndrome, weight gain, memory disturbance, and skin changes. Hypoadrenalism leads to orthostatic hypotension and easy fatigability. Diabetes insipidus, but it is almost never seen pre-op with pituitary tumors. If diabetes insipidus is present pre-op, then you have to look for number 1 craniopharyngioma, number 2 autoimmune hypophysitis, number 3 hypothalamic glioma, and number 4 suprasellar germ cell tumor. Then gonadotropin deficiency, and if it has anosmia, then it is part of Kallmann syndrome. Then there are other symptoms as well, like bitemporal hemianopia, obstructive hydrocephalus, cavernous sinus, leading to ptosis, facial pain, diplopia. Occlusion can lead to proptosis and chemosis. Then there can be engagement of the carotid artery. Nasal or paranasal masses, CSF rhinorrhea, and headache. Now we come to the pituitary apoplexy. It is actually expansion of the pituitary adenoma due to hemorrhage or necrosis. Typically presents with paroxysmal headache with nausea, meningismus, endocrinologic meaning loss of cortisol, and neurodeficit. It can be ophthalmoplegia, visual field loss, and hydrocephalus. So it is a medical emergency because it can lead to lethal adrenal insufficiency and the threat of permanent visual loss. Immediately, you have to give fluids and empirical corticosteroids, which are hydrocortisone, for hemodynamic instability, altered mental status, and visual deficit. Shunt for hydrocephalus or EVD can be done, and you have to do transsphenoidal decompression within 7 days for visual loss. If there is no symptom, then it is not an emergency. So actually what happens is that there is sudden expansion due to hemorrhage or necrosis, and sometimes the pituitary apoplexy can be the initial presentation of a pituitary tumor. If you look at it, then Ophthalmoplegia occurs more often in pituitary apoplexy than visual pathway deficit. So that is more important, that ophthalmoplegia occurs in pituitary apoplexy more than visual field deficit. And then hypocortisolism occurs. You can also find fluid and electrolyte disturbance and hemodynamic instability. There is reduced mental status due to raised ICP, and cavernous sinus compression can also happen. Other than that, hypothalamic involvement can also occur. So you do CT or MRI to look at the hemorrhagic mass in the sella turcica, and you do CT angiography to confirm it is pituitary apoplexy and not some kind of aneurysm. So how do you manage it? You give fluids and hydrocortisone, not any other steroid, just hydrocortisone. If there are no, if the patient is not having any emergency, then you look at their whole endocrine profile. And if the patient has prolactinoma, then you can give dopamine agonist. But if there is sudden constriction of visual field, severe rapid deterioration of visual acuity, or hydrocephalus, then you have to do rapid decompression. And so this is all about the pituitary clinical part. We will continue it in the next video. Till then, take care and thank you so much. God bless you.